Dorothy Doughty is our next speaker. If you have done the NCA course in Canada, you know her textbook, Doughty. There's been several editions of it, so we are very honored to have her come. I've heard her speak before, and I learned so much. It was wonderful. She has been a wound ostomy continence nurse since 1980 and was director of the Emory University Wound Ostomy and Continence Nursing Education Program for 30 years. Which is in Atlanta, Georgia, by the way, and she's currently working as a nurse clinician now at the Emory University Hospital. She has written books, has publications, presentations in many areas of wound ostomy continence nursing, and was the president of their society for a number of years as well. Do me a favor, when you see her, tell her that you love her outfit, please. And the reason I say that is that her suitcase was lost. So she is here presenting in what she was wearing on the plane. So it's very unfortunate, but she has a great attitude about it. So thank you, Dorothy.
Thanks, Grace. Yes, I told Grace it's going to make me rethink how I pack my carry-on, like maybe roll up some decent pants and put a little bit of makeup. So what I'm going to try to do today is cover what we currently know about constipation management. Great topic for right after lunch, don't you think? But you know, the gastrocolic reflex is active, so there's a lot of tie-in there. You already know a lot of this, so I'm going to just try to fill in some gaps and share some of the current research and trends in treatment. So you know a lot about constipation. You know that just like incontinence is a very prevalent condition, one that's frequently been ignored or treated very simplistically. So you deal every day with continence patients, and haven't their symptoms been to a large extent dismissed, like wear a pad, go away, you know, take this pill, and let's not talk about it anymore. Same thing with constipation, so very prevalent. As high as 33% in adults over 65 years of age, 5 to 10% of children have encopresis. And actually the incidence and prevalence of constipation is rising with the trend in aging, and also probably with our dietary patterns, which are not helping us at all. You know a lot about the relationship to urologic issues. What we already heard this morning, if you deal with dietary issues, dietary and fluid issues, correct constipation, and correct any urogenital atrophy, a whole lot of your people are a whole lot better before you even do anything else. And certainly we know that any kind of bowel and bladder issue has a very negative impact on quality of life. People with profound constipation, their whole world starts to revolve around, you know, trying to go. What am I going to take? I went to the bathroom, I strained, I spent all this time, nothing happened. So let's talk about normal bowel function, then we're going to talk about differential diagnosis of constipation, and then we're going to talk about a management pathway. So normal bowel function, not well defined, but in general it says that you have regular elimination of stool without pain, without straining, without having to use manual maneuvers, and that you don't have feelings of incomplete emptying. A very different definition than a definition based on frequency, which is what was used for many years and has caused a lot of problems. So in fact, normal frequency varies from 3 times a day to 3 times a week. And we want to try to move people away from that focus on, I didn't have a bowel movement today. Oh my gosh. I've promised myself that if I ever start counting my bowel movements, I'm immediately going to go in for therapy, you know. So let's talk about factors that contribute to normal bowel function. The critical thing, of course, is colonic motility. And the marker for colonic motility is stool consistency, much more stool consistency even than frequency. A number of things contribute to that. We certainly know that we have the enteric nervous system, all of the receptors within the bowel wall and the nerve pathways in the bowel wall that are very responsive to intraluminal irritants and to stretch of the colonic wall. So that means that when we go out to eat at this hole-in-the-wall restaurant that has fantastic food, probably much of the flavor coming from the unique blend of pathogens, mixed in with the food. What's going to happen the next day? We're going to be going a lot because the bowel is saying, what in the heck is that, and get it out of here. Okay, that's our body responding to those intraluminal irritants. We also know that if we get patients on enough fiber and fluid, that bulky stool stretches the colon wall, which activates the enteric nervous system and promotes bowel movements. So the enteric nervous system protects against irritants and responds to stretch. We use that every day in clinical practice. Autonomic nervous system also plays a role. We know that parasympathetic stimulation increases motility. Sympathetic stimulation reduces it, so that's a consideration with medications. It's a consideration postoperatively when we have high levels of sympathetic stimulation in response to stress. Our patients may develop an ileus and very frequently develop constipation. Levels of neurotransmitters. Serotonin is known to be an important neurotransmitter in the gut, and one hypothesized cause of chronic constipation is inadequate levels of serotonin. So some research is currently looking at how can we diagnose abnormal levels of neurotransmitters and what's the best way to treat that. But what I want you to see in bold, because this is an area of increasing emphasis, is the GI microbiota. So we know that there are more bacteria in the gut than anywhere else in the body. And we know that the right mix of GI bacteria is critical to colonic health. We also know that it contributes to immune system in general. We know that the interaction between GI bacteria and dietary fiber produces protective substances that keep the bowel healthy and help to keep us healthy. So the mix of bacteria in the bowel is critical. And what we're learning is that that particular mix varies from person to person, can be affected significantly by diet, may be affected by genetics, and that different bacterial mixtures produce different types of gases that have a profound impact on motility. So in the future, we may be using probiotic mixtures a lot more to deal both with diarrhea and with constipation, because we're now recognizing this as being so important. And we might be talking about dietary modifications from a whole different perspective, not only talking about fiber and fluid in terms of promoting normal motility, but also talking about dietary patterns that promote bowel health and dietary patterns that compromise bowel health and bowel function. And of course, you know the normal transit time for adults is less than 72 hours. Now, factors that contribute to constipation or to normal bowel function, you want normal sensory awareness of rectal feeling. So most of us have that. We're driving down the highway, we're gulping coffee because we're on our way to work, we're nibbling on a muffin or something because we didn't have time to eat breakfast. And all of a sudden, what do we get? We get an SOS from our rectum. Major delivery, pull over. Okay, well, what's just happened? That gastrocolic reflex plus the impact of caffeine has moved everything that was in our transverse colon down to our rectum and is about this far from our underwear, okay? So sensory awareness, very important to continence, as we know, but also important because we want our patients to learn to work with their body. When I have stool in the rectum, literally this far from my underwear, I also have that propulsive push, right? Peristalsis has pushed that stool from the transverse colon all the way to the rectum. All I have to do is open the sphincter and it's going to pass out. So we need to teach our patients, pay attention. And when you get that urge to go, instead of trying to shut it down and trying to delay, see if you can get to a bathroom so that you're working with your body instead of against your body. The second thing is people need to be able to coordinate abdominal muscle function and sphincter function. So when I'm trying to maintain continence, what do I want to do? I want to keep my abdominal muscles relaxed, and I want to keep my sphincter muscles tight. So if I am in traffic and I get the message, I have to say, I hear you, but I can't respond right now, not in the way you'd like me to. I'll take you as soon as I get to work. But if I'm 1 minute from a bathroom, I need to go to the bathroom, right? And I need to open the sphincter and I need to contract the abdominal muscle. So that ability to coordinate. And we know a lot about that from teaching patients how to coordinate pelvic muscle exercises in management of stress and urge incontinence. And finally, posture for defecation. So we know that the squatting posture is the best posture. We know that from lots of research. There's a muscle that runs around the anorectal junction. You remember that? It creates that acute anorectal angle that supports continence. But squatting and straining opens that angle so stool passes through the anal canal. Now, if we were in an Asian country, we would probably be squatting to toilet, and we would probably have much lower incidence of constipation. Western toilets do not support straightening of that anorectal angle. So we have to teach people. You need to be sitting with your feet flat on the floor. If you're having problems, you need to get a stool and you need to put your feet on the stool so that you get that correct angle. So how many of you have seen that squatty potty that's now available? Did any of you develop it? Because it's like, I hope a continence nurse developed that and got rich off of it. Probably somebody did and they're just not here, because why would they be here now? They're out spending their money. But anything to help facilitate effective evacuation. So dietary changes, fluid intake, prompt response to the urge to go, and the correct posture. Now let's talk about what we know about constipation. First of all, what is it? Well, this Rome 3 definition, and I have this mental picture of people sitting around tables and coming up with this definition of constipation. This is what they came up with. At least 2 of the following for at least 25% of the time for at least 3 months. And it's like, okay, you already lost me. With onset at least 6 months prior to diagnosis. Don't get lost in that. Just pay attention to what we already know. It's the things we hear from patients. I have to strain a lot. My stool's really hard. I don't feel like I empty. I feel like there's something in the way. I always feel like there's something there. And if I ask directly, people will tell me, yes, I have to use manual maneuvers. I have to digitally remove stool. I have to put 2 fingers in to split the vagina so I can pass stool, whatever. Patients don't know anything about that Rome 2 or 3 definition. They use a real-world definition, and I bet this is what you use in your practice. So it means I have trouble passing stool. Either it's really hard or dry, and so I have to strain a lot, and sometimes it hurts. I don't go as often as I used to, or I go very infrequently, only once a week or maybe twice a week. I have that sensation of incomplete emptying, or I have to strain a lot, or I have pain. Now again, frequency, you have 2 potential yardsticks. The best one is probably the patient's previous bowel patterns. If they say, well, I was normal up until, okay, well, what was normal for you? If they can't remember, then you're going to go back to that 3 times a week, at least 3 times a week. Some of our patients don't really have constipation, but they think they do. I don't see nearly as much of that anymore, but that is actually now a diagnosis, perceived constipation, usually because people think they should be going every day. Recognizing patients at risk is important because we have a lot of people who are at risk, and if we can intervene in an anticipatory model, and we can modify dietary intake, modify fluid intake, modify toileting behaviors, then we can keep them out of trouble. Huge issue for hospitalized patients, Huge issue for patients who require opioid pain medications, huge issues for immobile patients. So what are the risk factors? I think these are things you know very well. Females are higher risk than males because they have slower motility. The elderly, higher risk, slower motility. That's what the M means. Any neurologic condition that adversely affects innervation to the colon or levels of neurotransmitters, so certainly cord injuries, Parkinson's disease. Medication's huge. I should have put that in bold because we have so many medications that slow the gut. Inadequate fiber and fluid intake, we talk to patients every day about that. That altered microbiome, a huge thing to consider. And then inactivity, and finally psychological issues and sexual abuse that can be very problematic and can lead to obstructed defecation, which we're going to talk about. So remember when everybody considered urinary incontinence to be one condition? You know, there wasn't much of a differential, it was just you're wet. And I think we've done that for many years with constipation. We've treated everyone with constipation as if they had exactly the same process going on. But now we recognize that, you know what, that's not true. That there are actually a number of types of constipation. If we're going to be effective in managing this patient's problem, then the first thing I have to do is a comprehensive assessment so I figure out what the issue is. Now, simple transient constipation doesn't typically require intervention because that's what happens when people are hospitalized for surgery and they're put on opioids, and then as soon as they get off the medication, they're okay. Or travel disrupts many people's bowel patterns, or dietary changes. We're going to focus on functional constipation. That's what the patients that you're dealing with frequently have. We're going to differentiate slow transit constipation from irritable bowel syndrome that is constipation predominant. We're going to talk about dyssynergic defecation and encopresis. I'm going to give you a quick overview of each type, and then we're going to back up and we're going to walk down a pathway. So how do we assess? Where do we start in management? When do we refer? So functional constipation means there's no defined structural abnormality, but the gut is not working correctly. And it falls into two separate categories. At least 50% of the patients that we deal with who have chronic functional constipation have normal transit. And normal transit means there is really nothing wrong with the gut. If you provide that person with enough fiber, enough fluid to cause stretch on the colon wall, the colon will respond appropriately. If you reduce intake of anticholinergic medications, things that are artificially slowing gut motility. But up to 50% have slow transit. And with slow transit constipation, there's really something wrong with the gut. So you stretch the gut and there's no peristaltic response. You give them a stimulant laxative, there's no peristaltic response. You put them on fiber, they get worse. So pretty important to separate out normal transit and slow transit. IBS-C, irritable bowel syndrome, constipation predominant. The big difference with that is you also have pain. And we're going to look at each one of these. Dyssynergic defecation, the colon's okay, but they get into trouble right at the anal-rectal junction just when they're trying to eliminate the stool. And finally, encopresis in children. So normal transit, like we said, nothing wrong with the colon itself. These are the people that are pretty easy to fix. Once you educate them, help them understand. So the major causative factors are the things you already know and the things you deal with every day when you're talking to your patients. Not enough fiber, not enough fluid. How do you know that's a big problem? Because they report small, dry stools that are hard to eliminate. Many of these people are less active. Many of them are on anticholinergics. So sometimes you get patients who have already been seen by a physician who put them on an anticholinergic because they had a bladder problem. And now their bladder problem's not any better and their bowel problem is worse. And then, as we've said, poor toileting habits. Well, how do I know in talking to you that you've probably got normal transit? How am I going to differentiate that from slow transit? If I have normal transit constipation, I'm going to tell you that I have hard stools, usually, 2 to 3 times a week. I'm going to describe them as hard to eliminate. A lot of times I have to strain. Maybe I have a little bloating, a little abdominal discomfort. Most of the time, all I have to do is a history, just listen to what you're telling me, and y'all are so good at that, and then do a simple physical exam to rule out colonic distension, and do an anal rectal. Management pretty straightforward. Clean them out. Start with a clean slate, an open path. Look at their medications, try to reduce or eliminate constipating medications. Educate them. Talk to them about diet and fluids. And laxatives should be PRN only. These are the people you fix all the time. Slow transit, on the other hand, is just like that little belly-up frog, very bloated, like the people you see on TV, okay, where you have significant reduction in peristaltic activity. Things that normally make the gut work don't make the gut work because there's something basically wrong. It's like having a non-contractile detrusor, okay? So you have a non-contractile colon. These patients tell you a very different story. Stools 1 to 4 times a month and very large. Now, most of the time when they tell somebody in the healthcare arena that they only have bowel movements maybe 2 times a month or 3 times a month, they don't believe them. They're like, nobody goes that long. Yes, they do. Severe distension and bloating, because what's happening, the entire colon is filling before the pressures within the gut rise to a level to force the stool out. So the bowel literally fills proximal to distal, and then that's finally what triggers evacuation. Many times they do not have any urgency to go because the stool's in the proximal bowel, it's not down in the rectum, and they don't respond well to fiber. So what's the first thing everybody tells anyone to do if they say they're constipated? Eat more fiber. Because, of course, everybody has the same kind, right? So everybody needs fiber, not everybody. So again, listening, doing that physical exam, there's going to be clear-cut evidence of major colonic distension. And then that's the patient that I'm going to say, hey, this is a red flag for me. This is not your standard normal transit constipation. This patient needs a transit time study. So there's a couple of different ways they can do that. One way is they can do these little capsules that have wireless transmitters. And these little capsules respond to changes in pH as they migrate through the colon and send messages back to a receiver that says, okay, spent this long in the ascending colon, spent this long in the transverse colon. Pretty cool, huh? Or the old-fashioned, just give them SITS markers, those little radiopaque markers, and then do flat plates of the abdomen at routine intervals to see how long it takes to clear. How do I manage these patients? Very different pathway. So maybe stool softeners, but not very good evidence for stool softeners, so they won't hurt, but they're probably not going to help much either. So you know how we've acted a lot of times like, well, we don't want to put you on laxatives, but if you have slow transit constipation, I'm going to have to put you on laxatives. And I want to pick and choose based on evidence. So osmotic agents on a routine basis, stimulants on a PRN basis, along with targeted medications, and we'll come back to that. But see how these people are managed very differently than normal transit. And some of these people will end up requiring surgical intervention to remove a non-contractile section of colon. We recently had a woman who had failed everything, and we ended up doing an ileostomy for her, which improved her quality of life tremendously. Now, that's extreme, but it just goes back to how important it is to figure out what's going on. So what's the big difference between constipation predominant irritable bowel syndrome and, say, slow transit constipation? Pain. That's the big difference. So irritable bowel syndrome, patients complain of significant pain associated with abnormal bowel function. So say I have really awful cramping pain, tremendous bloating, I'm miserable. But then if I can finally have a bowel movement, I feel so much better afterwards. So you see pain and alteration in bowel function inextricably linked, and when you evacuate the colon, temporary relief in the pain. These people frequently also have extraintestinal symptoms, so they might have general feelings of malaise, they might have frequent headaches, they might have joint pains, so many other things going on, not just the gut. Why? We don't really know. We know there's a motility disorder. We know there's an abnormality in sensory awareness of peristaltic activity. So something wrong in the brain-gut axis. We're not really clear, but once again, all of the new studies are focusing on what? The GI microbiome. For IBS-D, diarrhea predominant, for IBS-C, constipation predominant, and for mixed. I think the more we learn about this, the more we're going to find that dietary modifications are going to be key to solving a lot of these problems. Now, when you're doing a workup on IBS-C, what you suspect to be IBS-C, again, you're going to start with history and physical exam. Diagnostic studies like colonoscopy is typically indicated only if there are alarm symptoms, okay? Unplanned weight loss, blood in the stool, nocturnal symptoms, marked worsening, because IBS-C is typically a pretty stable condition. How do we treat these patients? These people are usually young, so irritable bowel syndrome primarily strikes young adults, so it typically becomes manifest either in the teens or the early 20s, and becomes much less symptomatic, much less problematic after, say, the 50s. So it's primarily an issue from late teens to late 40s. Causes major issues with loss of work, many visits to care providers, lots of worry, because what's one of the cardinal symptoms or signs of cancer that we teach everyone? Alternating constipation and diarrhea, change in bowel patterns. And they're like, I've got both of those. Really scary. And so they think something is terribly wrong. So it's critical to sit them down and not brush them off. Not say, oh, no, you don't have cancer. No, everything's okay. You just need to do this. Well, that doesn't help me. You haven't told me what's wrong. You've made me feel like it's all in my head. Nurses don't do that. That's why nurses are really good to deal with these issues, because we're going to sit down and we're going to say, okay, here's what's going on. The good news is that it's not cancer. The good news is you don't need surgery. The bad news is that your gut is misbehaving and that we don't totally understand what's making it misbehave. We do know some things about management, but it's an ongoing thing. I can't give you a pill to cure you. I can't magically make it go away. Now, what do we know does help? Increase in dietary fiber, specifically psyllium-based fiber, Metamucil. Multiple randomized controlled trials have supported use of psyllium for IBS-C. Osmotic laxatives, like your Miralax type laxatives, as needed. And again, selected pro-motility medications. So we have all these new medications, but they're indicated primarily for your patients who have slow transit constipation and for your patients who have IBS-C, unresponsive to simpler measures. Dysenergic defecation. This is where everything's okay till you get down to the actual elimination of the stool. And even if stool consistency is normal, these patients tell you, I can't get it out. I can't push it out. I strain. Very little comes out. I still feel full. Why? When you do an exam, what do you find? They have that dysenergic syndrome. So they're bearing down, but what are they doing with their pelvic floor? They're tightening the pelvic floor, maintaining contraction of the sphincter, so they're creating an obstruction, not consciously, subconsciously. Perineal descent, rectocele, will also cause major problems with the ability to eliminate stool. And some of these patients have coexisting slow transit constipation, but many do not. Again, just listening, they tell you different things. It's like listening to a patient talk about OAB versus listening to a patient talk about stress incontinence. They tell you totally different things, right? Same thing here. So what do they tell you? I strain, I strain, I strain. I never feel like I empty. Do you have to do anything to remove the stool? Because I may not volunteer that. It's too embarrassing. But if you ask me directly, I'll say, yes, I have to use fingers in the vagina, or sometimes I have to put on a glove and I have to take it out. How do I diagnose that? How do I confirm? I do the anorectal exam. I find out what happens when I ask you to bear down as if you're trying to pass out stool. If I say I want you to open your sphincter and bear down, what do I find? They can't do that. They can bear down, but their sphincter stays tight. Or I can send them for a more involved test. But there's so much we can learn, and you do this every day in practice, from a good history and a simple physical exam. And then finally, encopresis in children. It's most commonly retentive encopresis, much more common than we realize. Nobody wants to talk about it, but what happens, many of these children have had a painful episode of constipation, and so they subconsciously withhold the stool. If I'm not passing the stool, the rectum begins to accommodate, so the rectal walls stretch. As the rectal walls become more stretched, I lose sensory awareness of rectal distension. Also, as the rectal walls stretch, it causes the internal sphincter to be chronically open. And then I start to leak liquid stool around that big fecal mass. So they have leakage and they have retained stool. Very negative impact. Parents feel terribly guilty, like, what did I do wrong? Did I do something wrong? Is there something wrong with my kid? Is she acting out? What's wrong with him? I don't even want to take them anywhere because they smell. I don't know when they'll have an accident. So the child's in distress, the family's in distress. But again, listening, doing a simple physical exam. You can do a flat plate of the abdomen. You can clearly see that distended rectum and sigmoid, sometimes extending into the more proximal colon. And again, this is a functional issue. There's nothing structurally wrong. So what do? We do a clean out. First of all, we make sure the child and the parents understand. This just happens. This isn't anything you did wrong. Okay? It's like Timmy wears glasses. Okay, we can solve this. So the first thing we have to do is we have to do a clean out program. Then we're going to put you on a toileting program. We're going to make sure you get enough fiber and fluid. We're going to continue to use laxatives to keep your bowels moving normally until we get back to normal function. It's going to take time for the rectum to go back to normal size, for sensory awareness to return to normal. Okay, so those are all the different types, but patients don't come in and say, I have this problem. I'm pretty sure it's slow transit constipation. I was wondering if you could help me. So you're always starting from the position of the unknown and trying to figure out what's going on. So you want to always start with, well, tell me what's normal for you. What's normal bowel function for you? And what's going on now? How often do you have bowel movements? What's the size and the consistency? Now, this is an interesting piece of GI trivia. Don't ask me exactly how they came up with this, but we now know that the optimal size for stool is about 2 centimeters. Don't you just wonder how they did that research exactly? So I'm not suggesting you measure, just keep that in mind, okay? So how often are you going? What's the consistency? Do you have small stools? Do you have pretty normal sized stools? Do you have very large, very bulky, very infrequent stools? What problems do you have? Pain, straining, incomplete evacuation? How are you managing? Are you using laxatives? Are you taking enemas? Are you having to use manual maneuvers? Tell me about your activity level. Walk me through a day. Let's talk about your diet and fluid intake. What do you typically eat for breakfast? What do you eat for lunch? What do you eat for dinner typically? How much fluid do you get? Let's talk about your medications and what's your med-surg history. You want to have the Bristol stool scale readily available. Everybody has it, right? Does everybody have this? And where do we want people? 3 or 4, ideally 4, right? So we want patients to be able to look at this and know what's normal and to be able to compare where they are and where they're going. What about physical exam? I want to do an abdominal exam to rule out colonic distension. So very simply, I'm going to percuss starting at the right lower quadrant, coming up the ascending colon, across the transverse, down the descending over the sigmoid and over the rectum. What should I find? On the right side, the ascending colon, the percussion note should be primarily resonant tympanic because it should be primarily air-filled. There shouldn't be a lot of stool on the right side of the colon. Over the transverse colon where stool is stored, yes, I'm going to have patchy areas of dullness. That's normal. What about descending sigmoid? Most of the time, tympanic resonant, unless I caught them just before a bowel movement and stool is moving down. What if it's dull to percussion all the way around? And when I palpate the left lower quadrant, I feel knots. And when I palpate the right lower quadrant, they're like, ouch, that hurts. Okay, that supports that diagnosis of FOS, full of stool. See, I was politically appropriate. And it tells me they're going to require a clean out. Then I want to do an anorectal exam. I want to see, can they do that coordinated maneuver, open the sphincter, contract the abdominal muscles? Do I see any evidence of rectocele or perineal descent? Okay, that would support a diagnosis of obstructed defecation. And is there retained stool? That has major implications for my management pathway. Just like it's very helpful to have patients with urinary incontinence do a bladder chart, equally helpful to have patients with fecal incontinence do a bowel chart, and I bet most of you have done that. So I've done my initial workup. I've listened to the patient. I found out how often they're having bowel movements, what their stool's like, how much they're having to strain, whether they have to use manual maneuvers, whether they're having a lot of pain. I've done my abdominal exam, so I know how much retained stool there is. I've done my pelvic exam, my anorectal exam, so I have ruled out or identified potential contributing factors to obstructed defecation. Now, what's going to fall out of that initial screening assessment are patients who need further workup, that I'm probably going to refer them to someone to get further workup unless I have the ability to order those diagnostic tests. If I pick up on indicators of slow transit constipation, I want to send them for transit studies, right? I need to confirm my impression. If I pick up on indicators of dysenergic defecation, obstructed defecation, I might send them for a balloon expulsion study where they literally put an inflated balloon in the rectum and see if they can eliminate that. Or for defecography, where they put contrast thickened to the consistency of stool in the rectum and then do fluoroscopy while they try to eliminate that. So now we're going to walk down the management pathway. Hopefully by the time we complete our assessment, we're pretty confident that we're dealing with normal transit, or we have identified patients who need further workup to rule out slow transit or obstructed defecation. Many of our patients will need a clean out. I know you've had lots of patients come to you and on initial assessment, they're absolutely full, their colon is loaded. How many times are they even unaware of this? I've had so many patients in our center say, why are you asking me all these questions about my bowel? That's not what I'm here for. I came here for my bladder. My bowel is fine. And we're like, well, actually, there's a lot of evidence it's not so fine. And you're getting complaints from its next door neighbor, the bladder. So let's evict all of that retained stool and see how your bladder does. So If we're doing a clean out, we're going to start ideally with a top-down approach, laxatives. Most people would much rather take laxatives than do enemas or suppositories. If they have a laxative they use, easy. I can either double the dose and tell them to take it nightly till they're passing mushy stool, or use their routine dose nightly till they're passing mushy stool. But there are some patients that I have to do bottom up. If they're impacted, I can't start top down. I have to eliminate the plug before I can clean out the rest of the system. And certainly for people who have very poor sphincter control, I'm going to do bottom up because time frame for response to an enema is much more predictable than time frame for response to a laxative, and I don't want to precipitate a lot of incontinent episodes. Hopefully, we can do gentle digital breakup and then do a cleansing enema and an oral laxative. What if it's too hard to pass? It's too big, too hard for them to pass and for you to break up. You know, they always say, well, give them an oil retention enema. But that's all they say. Well, obviously that's not enough because they essentially have a bowling ball in there. And even if I slick it up with mineral oil, it's still a bowling ball. Okay, so I've got to do more than that. So here's what we should do. We should do warm mineral oil enemas for 2 to 3 days, recognizing that it takes time for that to take effect and to start softening that stool. Or I could do a half and half mixture of milk and molasses. Very effective because it's very hypertonic. So equal parts milk and molasses warmed till you can stir it all together. Then cool down till you can administer small volumes. So we typically will administer 2 to 3 ounces at a time right around the retained fecal mass. Wait 30 to 45 minutes, attempt breakup. Repeat until you can break it up and they can pass it out. And usually you can get them cleaned out within a couple of hours. Okay, so I've got them cleaned out. Now I'm going to educate the patient, get the patient on board with the program. I want them to understand what's going on, why they got constipated in the first place. I want them to understand the importance of fiber and fluid. I want them to understand the importance of working with their body instead of against it. And maybe they need a prescription for a squatty potty, okay? But they certainly need to know about the correct posture. And we have emerging data that patient education does make a difference in outcomes. A lot of times, you know this, patients just get handed stuff. Do this, do that, take this. But nobody sits down until they get to your center. Nobody sits down and says to them, this is what's going on. This is why you're having these symptoms. Here's the management plan. We're going to do all the things we can do, all those behavioral things you do every day. What can I do to increase activity? Can I give you a prescription to walk a certain amount every day? Can I work with your prescribing provider to reduce or eliminate constipating medications so that we're not fighting an uphill battle? And then what can I do to make sure you're getting the right amount of fiber and fluid? Current guidelines, women need about 25 grams of fiber a day, men need about 38. You take all the different types of fiber together, what do? You know this, they soften the stool. They also increase bulk, and when you increase bulk, you stretch the bowel wall. That stimulates peristaltic activity. So fiber increases motility. And we're now recognizing that fiber promotes microbial balance. Microbial balance also contributes to stool bulk and to normal peristaltic activity. But we have to remember that if I have a patient who looks like they have slow transit, that fiber may not be the right way to go. If I use fiber, I have to use it very cautiously. We all know there's different types of fiber. When it comes to bowel function, it's all good. Assuming relatively normal GI tract function, both soluble, insoluble, helpful. Soluble fiber obviously dissolves in fluid. What does it do? It softens stool, it promotes microbial balance. Doesn't have as much of a stretch effect, okay? Doesn't add that much bulk, mainly acts as a very effective softener. Major dietary sources, your fruits and vegetables, the pectin. And from a fiber supplement perspective, Fiber Choice is soluble, Benefiber, and Psyllium. All of those are good choices for for soluble fiber. Now notice that Psyllium is fermented to a lesser extent than things like your guar gum and your inulin. So people usually have less gas with something like Metamucil than they would with, say, Fiber Choice or Benefiber. That can be an important consideration when you're making fiber recommendations. What about insoluble fiber? It doesn't dissolve, and it adds mass. So it's really going to help stretch the bowel wall and increase motility. So you think of soluble fiber as a softener. You think of insoluble fiber as a stimulant to peristalsis. Dietary sources is going to make sense. These are things that don't dissolve in water. Flaxseed, wheat bran, your whole grain cereals, your raw vegetables, your vegetable peels, your nuts, your seeds, and interestingly, citrusel, methylcellulose. The other good thing about insoluble fiber and things like citrusel is that it doesn't get fermented, so you have much lower gas production. So within the world of soluble fiber, if you're recommending a supplement, you're probably going to go more with the Metamucil type. If you're recommending insoluble, you're probably going to go more with something like citrusel. Lots of high fiber foods. Probably a lot of you have a printout that you give patients and you're like, here's your goal. Now, what you like is different than what I like. I want you to focus on your goal. Here's the data you need. What if I'm like, I'm not going to change what I eat? I used to work with spina bifida kids, and so I would say to the kid, mom would be sitting here, kid would be sitting here. I'd say to the kid, so if changing what you eat or drink would make a big difference in how well your bowel works and whether or not you pooped your pants, would you be willing to change what you eat? And the moms would always say, of course. And the kids would be like, no. Who should I believe? The kids. But here's the thing. In 2016, I think I can get fiber in anybody, right? Because there are gummy worms that are fiber enriched. There's water that's fiber enriched. If it's too much trouble for me to stir it in, I can pay somebody to stir it in for me. You know, so I can put fiber on your food and you don't even know you've got it. You can get fiber into anyone. You just have to know what their preferred pathway is. Do you want to do it dietary-wise? Would you rather do a supplement? Within a supplement, do you want something that you stir? Do you want a tablet, you know, or a pill that you take? Do you want a gummy worm that you eat? Do you want fiber-enriched water? What do you want? Bran mixture, very effective. The studies that we have so far indicates that bran mixtures have a normalizing effect on motility that we don't even totally understand. So you can always mix bran and applesauce and prune juice and then start out with 2 tablespoons a day and gradually titrate to desired effects. People who do this will tell you it's very effective, but the other half of the world takes one look at it and says, that looks gross. And I'm not eating it. Okay, so that's why different things work for different people. You know that in starting fiber, that we've got to make sure they're getting enough fluid, that it's best to titrate upwards with weekly reassessment of where are we to, do we need to increase your dose, that if you're taking a soluble fiber that gets fermented, that I have to warn you about the potential for increased gas. That's particularly obvious the first few weeks. If I have a patient and I suspect slow transit, I'm going to start very slow. I'm going to start primarily with soluble, and I'm going to tell them, you know, if you start having increased bloating, increased cramping, I want you to stop and call me. I have to be aware right up front. What about stool softeners? Patients ask for stool softeners. Do your patients ask for stool softeners? My patients are like, shouldn't I be on a stool softener? I'm like, well, it won't hurt you. That's true. It probably won't help you. They're very widely used, but look at the bottom bullet point. The data really does not support stool softeners as being very effective at all. Fiber is a better choice. So they won't hurt. They're supposed to reduce the surface tension to allow water reabsorption. At best, they have no impact on motility, and they might make the stool a little softer. Probably they have more a placebo effect than anything else. But what about probiotics? What about that whole GI microbiota? I think we're going to hear more and more about this. We're in the pioneer days of how to use probiotics. And one systematic review looking at 11 randomized controlled trials, they were able to show that bifidobacterium reduced transit time, so helped stool move through the colon faster. So that was one probiotic that was studied. The other one that's been studied a lot is lactobacillus. Some studies have looked at the combination of bifidobacterium and lactobacillus. But you look at all the bugs in our gut, and you realize we don't know very much. We have a lot left to learn, right, about which ones to use when. You know, what specific effects. There's one type of organism in our gut, Prevotella. And one study showed that constipated children had much lower levels of Prevotella than non-constipated children. So that suggested, well, maybe Prevotella is a probiotic we should be looking at. Another study said, oh no, Prevotella is associated with bad things in the gut. It's a negative. So you see how far we have to go. The problem with probiotic usage and management of constipation at present is that we have very little definitive data. We need a lot more studies about what type of probiotics to use, when to use them, and what's the optimal dose. But we should definitely stay tuned and watch emerging data because it all ties in to normalizing that GI microbiome, which will probably go a long way toward normalizing function. I'm going to very quickly talk about management of special populations. So we've talked about primary management. But when you look at special populations, it includes patients with opioid-induced constipation, IBS-C, slow transit, and obstructed defecation. So we know we have lots of patients with opioid-induced constipation, and until this point, we've just had to use laxatives kind of as a counterpoint to the negative impact of opioids on GI tract function. But now we have one widely used or fairly widely used opioid antagonist. So it's an agent that blocks the opioid receptors on the bowel wall, but has no impact on opioid receptors at the level of the central nervous system. Translates into no interference with pain relief, but marked reduction in opioid-induced constipation. So that's methylnaltrexone or Relistor. But it's given sub-Q and it's expensive. So we need better options. So they're looking at naloxegol, which is oral instead of sub-Q, and that's becoming increasingly available. They're also working on developing combination drugs. So taking oxycodone, which we know will shut the gut down, and pairing it so that you get one pill with two effects. You get pain relief, but you also get protection for bowel motility. So a lot of work in that arena that's going to be tremendously beneficial for our patients. Right now, many of our patients are still dependent on those bowel programs. So you're on opioids, you should probably be on something like Miralax, and stimulant laxatives as needed. What about slow transit? We've already talked about stool softeners. We've said osmotic agents are beneficial on a routine basis because they pull fluid into the gut, help to soften the stool, and help to stimulate motility to a little bit of an extent. Stimulant agents like senna and bisacodyl PRN. But here's an area where we have a number of emerging drugs, targeted medications designed to increase peristaltic activity in patients with slow transit constipation. This is an important message, I think, for us to give our patients. Our patients were raised like many of us were. How many of you were taught laxatives are a bad thing? We should only use them very short term, get them off of them as soon as possible, or you'll make them laxative dependent. And that whole term, laxative abuse, that sounds like drug abuse. So what happened? I took 2 Dulcolax and I felt so good. I was so happy. I just couldn't resist. The next day I took 3, and pretty soon, you know, it just goes on and on. So the new data says that unless I have an eating disorder, the only reason that I would be taking Dulcolax in the first place is because of constipation. That's what triggered the overuse of laxatives. So now, gastroenterologist, I can never say that, GI physicians have looked a lot at this laxative hierarchy. And so at the base, we have our fiber-based supplements, which really aren't laxatives, they're just supplements, and they're safe for routine and repetitive use. But if I have any concerns about slow transit, I've got to start low and go slow. Osmotic agents. A lot of our laxatives are osmotic. They work by pulling fluid into the gut. Pulling fluid into the gut softens the stool, creates stretch, triggers peristalsis. So your magnesium-based, your saline-based, your polyethylene glycol-based, your lactulose, your sorbitol, all of those essentially work by pulling fluid into the gut. And guess what? They are safe for repetitive use. So you need to be able to say to your patients, you can use these routinely. And because of what's going on with your gut, you need to use them routinely. Now, stimulants, we do want to limit to PRN use because there's some evidence that they might truly reduce motility long-term if we overuse them short-term. But osmotic agents are physiologic. So we just talked about that. I do want to point this out. The last point, that we now have a number of studies that show that polyethylene glycol is particularly effective within that category of osmotic agents. So if you have patients who have slow transit and they require repetitive use of laxatives, that's a very safe one to use. We talked about that. So the last couple of things I wanted to go over, I wanted to just tell you about some of the drugs that are being researched or being used more and that are coming. Certainly you're familiar with lubiprostone or Amitiza. Linaclotide works the same way as Amitiza, and that is they both increase secretion into the lumen of the bowel, which helps to fluidize the stool and stretch the bowel wall. So those are approved for slow transit constipation that does not respond to other therapies. What about prucalopride? Now that's a unique medication. That's based on serotonin levels and increasing serotonin levels, and it has a direct impact on peristaltic activity. So actually a different mechanism of action. And there's a study looking at vibrating capsules to see if you can shake it loose and down and out, okay? The last couple of things that I'll mention for patients with slow transit constipation, you heard how effective sacral nerve stimulation can be for both refractory OAB and urinary retention, and also for slow transit constipation. So in about a third of patients, sacral nerve stimulation can make a huge difference, and certainly much less invasive than other procedures and worth a trial because it is a two-step process, so worth evaluation for patients who have failed pharmacologic therapy. On the more extreme end, the ACE procedure, where you literally remove the appendix or take a small segment of bowel and tubularize it, and then attach one end to the abdominal wall and the other end either to the ascending or the transverse colon, so that the patient can feed in a red rubber catheter, a small catheter, sit on the toilet, and literally flush their bowel proximal to distal. Has been very effective both for children with neurogenic bowel and for patients with slow transit. So I want to just summarize. Our critical role is to hear our patients. We do that so well, to listen to them, to ask the critical questions, to do our focused physical so that we have a pretty good picture as to what's going on. Behavioral therapy remains first line. No change there. So patient education, eliminating constipating meds, making sure they're getting fiber and fluid, especially for those patients who have normal transit. If we have a patient with slow transit constipation, we're going to have to use laxatives and or targeted medications to keep their bowel working, and they may end up needing surgery. If they have dyssynergic defecation, they may benefit from biofeedback to teach them how to coordinate abdominal muscle function and pelvic floor muscle function. They may benefit from Botox. And children with endocaprices are going to benefit from behavioral therapy, clean them out, get them on fiber and fluid, get them on a toileting program, keep them on laxatives until their bowel function normalizes. Thank you very much.